My name is Allison Brooks, and I am a now retired gynecologist who heads up the Women's Health Institute. And Stacy and Dr. Selecki have contacted me many times over the last year asking if I could please get Dr. Moyeri to come and give her presentation on polycystic ovarian syndrome, because I think there have been many requests to have that level of expertise, because what starts out as something that we diagnose and treat in the teenage years can have lifelong implications. And you will be in for a real treat having Dr. Moyeri speak to you today. I think many of you probably know her father, who is a medical oncologist locally for the past, I think, 35 years or so. She also has a sister who's a neurosurgeon in the Bay Area, so if any of you need to refer to a neurosurgeon, she'll pass out her cards as well. But Dr. Moyeri did all of her training, her medical school and undergraduate at UC Irvine, followed by her fellowship at Stanford University. And she has been here in private practice in reproductive endocrinology and infertility over the last 8 years. She is double boarded in both OBGYN and reproductive endocrinology and infertility, and she is very well published both in peer-reviewed journals, manuscripts, chapters in books, and she is an absolutely lovely, well-spoken, articulate, and occasionally funny if you make her feel comfortable. So you can laugh and applaud at any point that you want. So just a quick reminder on the learner objectives. Today you will be hearing about polycystic ovarian syndrome, its diagnosis and related pathophysiology. Identify risk factors of and conditions related to polycystic ovarian syndrome, diagnose and evaluate comorbidities related to polycystic ovarian syndrome, and to characterize goal-specific therapy. There are no financial disclosures for Dr. Moyeri, and the content of this activity was vetted by the CME executive group. And bathrooms are around the corner, cell phones on vibrate, and Dr. Moyeri will be up.
So thanks for having me here to talk about polycystic ovary syndrome. This actually used to be my least favorite topic through fellowship training, but now it's become one of my favorite because it's complicated and it's not well understood. So I enjoy it now, seeing so many patients who do have this. So as we talked about, my objectives today are to describe polycystic ovary syndrome, how it's diagnosed, and the related pathophysiology, because there's many. We're also going to try to identify some risk factors and conditions related to PCOS, since patients come to the office often not knowing what it is that they're experiencing, so it's important to be able to identify if they're at risk or not. And we're going to talk about the diagnosis, which is still often controversial, and then evaluate any comorbidities that are important for the lifetime of a woman who's suffering from polycystic ovary syndrome. And then most importantly, we're going to characterize some of the goal-specific therapies, part of which depends on where the woman is in her reproductive life and what her specific complaints are. So the American College of OBGYN has an updated, which seems outdated by now, but it's from 2009. But this was a big change in their management guidelines for obstetricians. And I haven't seen anything since then, but basically my talk is mostly based on the recommendations and guidelines presented in the ACOG bulletin from 2009. So what is polycystic ovary syndrome? First, it's important to know it's a syndrome, not a disease. It was first recognized in the 1800s when there was the observation of polycystic or sclerotocystic ovaries through operative procedures. Stein and Leventhal actually characterized the syndrome to include, in addition to the enlarged ovaries, obesity, hirsutism, and chronic anovulation. So you can see here this woman is kind of a classic demonstration of polycystic ovary syndrome, one that I have never seen in my clinical practice, and so it's a little bit misleading because this is not typically how our polycystic patients appear. A good kind of summary to remember what polycystic ovary syndrome is it's also described as syndrome O, ovarian confusion, ovulation disruption, overnourishment, and overproduction of insulin. So it's a nice little mnemonic to think about when you're thinking about your patients in the office. It's really not a disease. It's a constellation of signs and symptoms. Sometimes it's difficult to diagnose, partly because it has a very variable phenotypic presentation, depending on which genes might or might not be activated and lifestyle factors. It also is really important to recognize that polycystic ovary syndromes, the symptoms change as a woman ages, since a lot of the symptoms evolve from the ovarian pathology. As we well know, that the ovaries continue to decline their ovarian function over time, and so it's not that the woman no longer has polycystic ovary syndrome, it's just going to appear different in her older years than it did in her younger years, which can be very confusing for patients and clinicians who are evaluating them at different times of their life. There's no single test or feature that is diagnostic. So, what is it? Well, you see that 50% or more experience obesity. Insulin resistance is extremely common, whether or not the patients are obese. It occurs in about 70% of the population. Irregular cycles or long cycles or patients who aren't ovulating occurs in about 70% of the subjects. Androgen excess is quite common, and this is probably the most characteristic feature of polycystic ovary syndrome. And we're going to focus more on this because historically we focused on the ovarian physiology and appearance, and we realized that that's probably not the most important or consistent finding, but this elevated androgen is really important. Some patients might complain of hirsutism as well as polycystic. This should be polycystic appearing ovaries. So this is just the ultrasonography finding or the what you see if you were operating, for instance. It is the most common endocrine abnormality among women of reproductive age. A lot of people argue that it's underreported, partly because people don't fit the stereotypic definition that we've used historically. It affects at least 10 to 15% of women, and there's definitely an ethnic predilection. So Latinas have the highest risk at approximately 13%, and I've even seen some reportedly as high as 20%. Caucasians and African Americans have relatively lower percentages, and I didn't include on here, but Asians can be among the hardest to diagnose, but they have probably comparable to Caucasians of 5% risk of having this condition. It certainly seems to be hereditary. You do see affected mothers and sisters up to 40% of the time. And another important family history to observe is that you can see male members of the family obviously not having polycystic ovary syndrome, but having diabetes. So even though the mothers may not have the classic polycystic ovary syndrome, you often will see heart disease, lipid abnormalities, and diabetes in the father's side. Okay, so etiology and pathophysiology, we're going to get more in depth on this. It's actually not clear, why people have polycystic ovary syndrome, but there seems to be some sort of irregularity occurring in the brain that causes increased relative LH production compared to FSH production. There also seems to be some relationship to elevated insulin, either in the insulin action or its secretion. And then classic sign you'll see is androgen excess, primarily from the ovary, but also from the adrenal gland. So if you look, a normal menstrual cycle has this reddish line is your FSH, and the yellow is your LH, the luteinizing hormone, follicle-stimulating hormone. In a normal cycle, you have a predominantly FSH environment in the follicular phase, and you get this LH surge around the time of ovulation, and then the hormones drop again with a predominantly FSH to LH ratio. In a woman who experiences polycystic ovary syndrome for various reasons, again, that are not completely understood, there'll be a predominance of the LH throughout the cycle, thereby preventing ovulation since the FSH is relatively suppressed. So what happens with that excess insulin in the patients? Well, you see decreased binding of proteins with increased androgens then floating through the system that lead to certain characteristic features as well as abnormalities in the blood. One of those would be abnormal cholesterol levels with a reduction in the good cholesterol, as well as an elevation in the bad cholesterol, the LDL. We see that the risk among PCOS for insulin resistance is quite high, at about 50% or more, and up to 70% in some patients. And all those patients really need to be screened for diabetes, even the thin patients, because I've seen many, many thin patients who actually do have borderline diabetes, and if they're not screened, there's no way to have identified them. So it's important to screen patients who are diagnosed with PCOS, whether they're heavy or not, for diabetes. Acanthosis nigricans is demonstrated here. This is an effect from the elevated insulin, and it's a classic predictor of elevated or abnormal insulin function. So it's often this kind of dark patching that you'll see under the armpits, around the back of the neck. And for the GYNs, it's easy. When you're doing your pap smear, you'll often see it in the groin area. So it's an easy thing to pick up in your history and physical. And although it's often difficult to diagnose insulin resistance through biochemical markers, you certainly can use this as a surrogate for insulin issues. So other problems with that androgen excess, so we talked a little bit about the insulin effects, but androgen excess in these women actually is worse if they also have insulin problems. And it's a very common feature. About 80% of women with polycystic ovary syndrome will complain of excess hair growth in a pattern that's not desirable for women. So they'll have kind of mid-central of the body hair growth, chin, chest. And acne is another common problem, but not as common. And some of these are hard to diagnose since people treat them. So you may not recognize it during their visit, but it's important to ask them. The other thing you might see is hair loss, but it's typically androgen driven, so more like alopecia in the frontal or the back of the head that you would see typical of a man, not necessarily global throughout the whole head. So that's an important feature to observe. So what is kind of a unifying theory that brings together this idea of excess insulin and excess androgens? We don't exactly know the source, but we do know that there's something going on at the neuroendocrine level that alters the pulsatility of the GnRH. So at the hypothalamus, you'll see altered pulsatility. Whether that's the cause or effect is unclear, but that creates a preponderance of LH, which affects, this is now in the ovary, the thecal cells of the ovary, which are androgen-producing cells of the ovary, to produce excess androgens. And if in fact they do have hyperinsulinemia, which is common, the insulin acts to promote this androgen production within the ovary. So now you're having multiple sources for the excess androgens at the level of the ovary. And then this excess androgen will be converted to estrogen within neighboring cells in the ovary called granulosa cells. And this excess estrogen is important clinically, partly because it'll prevent them from ovulating, but partly what we'll describe later is it could lead to certain health risks in those patients that could actually be very significant and serious in the long run. So we need to remember this excess estrogen environment as well as the excess androgen environment, which are closely related to one another. So we talked a little bit about, there's a lot of genetic and phenotypic variation, and part of that is because there's multifactorial causes for PCOS, and each kind of modifies how these patients present. So there's certainly some susceptibility genes, some that are being identified, and continued research is going on in this area. Then there's modifier genes, some of which we think occurs in utero when the mother is pregnant with the child, female fetus. And then the environment, of course, affects their presentation and the extent of their symptoms and signs. So here are some of the genes that have been implicated, and you can see this is a relatively long list, but it's continuing to expand. And so depending on which genes might be involved and whether they have one or two copies of those genes, you might see some significant variation in phenotypic presentation. So to summarize, the pathophysiology of PCOS, although we don't know the exact etiology, we do understand something about what's going on in the body to lead to these changes. The hypothalamus as well as the pituitary are important factors with an alteration of LH to FSH secretion, blunting ovulation since they don't get their LH surge. That promotes more androgen production in the ovary, which eventually leads to more estrogen production in the ovary as well as in the peripheral fat cells. And so all of this leads to further blunting at the level of the pituitary of the LH to FSH, so that you have a preponderance of LH. And so this all works kind of in synchrony to continue to support an anovulatory environment. And it also, of course, leads to some of the side effects of hirsutism, acne, and insulin resistance. So how do we diagnose PCOS? This is extremely controversial and constantly evolving. And so I'm going to describe historically the definitions that we've used and how they've evolved. And the truth is, there's no one specific feature. So NIH came out with some guidelines in 1990. Those were replaced by 2004 Rotterdam criteria. More recently, we have the 2006 Androgen Excess PCOS International Society. I think this probably is the most consistent and accurate in terms of what we see clinically. And then, of course, more recently in 2012, although this isn't used for diagnosing PCOS, they've tried to characterize the different phenotypic variation to make it easier for people to conceptualize patients with PCOS and how they don't fit that classic picture that I showed you in the very beginning. So the NIH really is less inclusive. They required excess androgens, either diagnosed through clinical signs such as hirsutism or acne, or by biochemical markers of elevated testosterone, DHEA, sulfate. In addition to that, it was necessary to have some menstrual irregularities, and it doesn't have to be that the patient doesn't ovulate at all. It could be that they have longer cycles or oligomenorrhea, typically defined by cycles longer than 35 days. There's no mention in this criteria of the polycystic appearing ovaries, which is interesting since the condition is labeled after the appearance of the ovaries. This makes it very confusing sometimes for patients to understand. The Rotterdam definition in 2004 was more inclusive, requiring only 2 of the 3 criteria to be met. So in addition, the hyperandrogenemia, as we already described, menstrual irregularities, as we've already described, but then they added this polycystic ovaries as a third possible criteria to be met. So any 2 of these 3, and none plays a more important role, 2 of these 3 need to be met in order for someone to have the diagnosis. So this is really the key difference, is this third criteria. One thing to always remember, though, before you label someone with polycystic ovary syndrome, it's really important to exclude any other endocrinopathy. So you have to make sure that they don't have thyroid disease, they don't have elevated prolactin, and then no issues with their adrenal gland, because they can mimic signs and symptoms of polycystic ovary syndrome, and those are treatable conditions that need to be addressed before you can label someone with polycystic ovary syndrome. So ACOG practice bulletin that I had previously mentioned summarizes this nicely with the different criteria. And in 2006, the Androgen Excess Society, so this is the first one we described. This is the more recent Rotterdam census. And then now we have the 2006 Androgen Excess Society coming up with the most important feature being the androgen excess. So that is a required part of the definition. So either patients need to present with some complaints related to excess androgens, and again, since people now do all kinds of things to remove hair growth, it's sometimes hard to pick up just by physical examination, so you need to ask them specifically about that. And then same thing with acne. Acne can be treated very easily these days, so sometimes they do suffer from acne, but it's not visible upon physical examination. But this is a mandatory part of the criteria. And then one of the other 2 features needs to be present as well. So they pay preferential attention to the hyperandrogenemia, but either irregular cycles or oligomenorrhea and ovulation, or polycystic ovaries by ultrasound appearance. So either of those 2 would qualify, again, excluding any other endocrine problems. So this is generally what I use to diagnose my patients. And then sometimes it's more of a you've done it long enough, you kind of recognize it. So it kind of goes along with the lifestyle factors that might be modifying their physical presentation, and so that might make it harder to pick up, particularly among Asian patients who tend to be thinner and don't have the excess hair growth typically. Okay, so we did talk about the NIH coming up in 2012 with some ways to better characterize these patients. And so when I do call my patients PCOS, I try to identify what features led to that diagnosis. So here are 4 phenotypic categories that they've come up with. And one important thing to see is that none of them use polycystic appearing ovaries, which is abbreviated PCAO, polycystic appearing ovaries, as a sole criteria. And oftentimes I'll get patients sent from elsewhere who said, oh, my doctor or my the radiologist or tech did an ultrasound and told me I have polycystic ovary syndrome. It can't be diagnosed that way because other things can look that way on ultrasound and the patient may not meet the other criteria. But the first and foremost category is androgen excess with ovulatory dysfunction. That's the more common group that we see. But having androgen excess with polycystic appearing ovaries can also qualify them. Ovulatory dysfunction with polycystic appearing ovaries is another common presentation. And androgen excess with ovulatory dysfunction and the polycystic appearance of the ovaries. This is kind of inclusive of all 3 features. These patients, in my experience, tend to be the ones who have the most significant endocrinopathies. So they have more presentation and hormonal abnormalities on blood tests. Okay, so how do we evaluate these patients? First, you got to think about what else could be going on. So you want to know, do they have hypothalamic amenorrhea, which is often idiopathic, but could be related to lifestyle if they're super athletes. Sometimes this is very interesting because you'll see polycystic appearing ovaries on these patients. So it might be very hard to distinguish just from ultrasound, especially if you've got a polycystic ovarian patient who's thin and is very athletic. So it's important to use your hormones to guide you in that situation. If they're not ovulating, you certainly want to rule out premature ovarian failure. If they're not having periods, they can have hirsutism that's unrelated to any other endocrinopathy, and that's often idiopathic or ethnic based. So it may not be that they have polycystic ovary syndrome, they just might have excess hair growth. You certainly need to rule out thyroid disorder and hyperprolactinemia, as well as any of the adrenal syndromes. An important thing to consider in those patients is metabolic syndrome, because often you'll see that as part of this syndromic population, especially if they're obese. And then, a lot of our tests are driven primarily to rule out bad stuff. So we want to make sure that there's nothing funny going on, especially if they've had rapid onset of symptoms. It's not something that they've always experienced. If they come to you complaining of hirsutism and it's relatively new and rapid developing, well, you certainly need to rule out bad stuff from the ovaries, from the adrenal gland, or from the brain. Drugs could certainly cause it. People do a lot of herbs now. Herbs are medications as far as I'm concerned, and sometimes you'll see alterations in their menstrual cycle and or skin changes such as acne development or hair growth that could be related to some medication that they didn't think was a medication but was an herb, for instance. And then there's another condition called Hirsutism syndrome. For me, this is more of a variation of polycystic ovary syndrome. The acronym stands for hyperandrogenism, insulin resistance, and acanthosis nigricans. So this is one form of polycystic ovary syndrome. So the menstrual dysfunction is quite common. About 30% will have oligoanovulation, so they may still have periods but longer cycle lengths. 2/3 will experience some sort of irregular menstrual cycle, whether you look at no ovulation or long cycles. Often, which is interesting, patients will think they're ovulating and they'll give you normal menstrual cycles. They figure, roughly every month I'm having a period. But if you actually tried to confirm ovulation, you'd see that in about 25% of those patients who have PCOS, although they describe cyclic bleeding, there's no evidence that they actually ovulated. So there's some ovulatory dysfunction, even though they are reporting a normal pattern of menstrual cycles. The consequences for PCOS will go into more detail, but can be related to, dysfunctional bleeding, infertility, and endometrial hyperplasia. This is the important feature that we're going to remember to discuss related to that excess estrogen that I had discussed early on that occurs as the androgens get converted to estrogens in the ovary as well as in the adipose tissue peripherally. Okay, so how do you identify polycystic appearing ovaries, which I'm abbreviating the PCAO, not to be confused with the syndrome? Sometimes people have only had a transabdominal approach, which is hard to pick up, so you really need to do a transvaginal ultrasound to get a good view of the ovaries. If the patient is very heavy, it could be hard to see the ovaries clearly and to really be able to identify the follicles, which are these little kind of round circles in the ovary. You have to remember that follicle reserve continues to decrease as women age. So although they may have had polycystic appearing ovaries when they're in their 20s and 30s, if they're presenting in their 40s, they're not going to necessarily have ovaries that look this way anymore. And so just because they don't have polycystic appearing ovaries doesn't mean they don't have the syndrome. One of the more recent definitions includes having an excess of 12 antrofollicles. Antrofollicles are those follicles or cysts on the ovary that measure less than 10 millimeters. So this is also confusing for patients because their doctors tell them they have cysts and they think of that as something very abnormal that needs to be surgically treated, but the cysts are really just the excess follicles in the ovaries. Volume of more than 10 milliliters, and then this string of pearls distribution is controversial. It partly depends on the amount of androgen excess that they have, whether the string of pearls occurs. The other important thing to note is that this is a very subjective, although we're trying to impose some objective markers, but it's a fairly subjective assessment of the ovaries. Again, polycystic appearing ovaries does not equal PCOS. That's the one thing that's important to remember, if nothing else, from this meeting. So that's something that I think I hear all the time with patients, and they get nervous because they had a scan and that's how they were diagnosed, and it's not always the case that they have it. I like to use the rule of 20s, which kind of is the rule of 20s to 30s, but I keep it simple. So polycystic ovary syndrome, 20% of patients will not have polycystic appearance on their ovaries. And I think if we really start to look throughout a woman's reproductive years, you'd see that this number is higher. Oftentimes people don't think to evaluate polycystic ovary syndrome in women who are in their late 30s or early 40s, and I think you'd see that they're less likely to have polycystic appearing ovaries as they age. Polycystic appearing ovaries on ultrasound will predict polycystic ovary syndrome about 20% of the time. That's much lower than what people are led to believe. But about 20% of the time, they will not meet the other diagnostic criteria. So what else could there be that's going on? Again, hypothalamic amenorrhea, women who are anovulatory due to some miscommunication between the brain and the ovaries, will have oftentimes polycystic appearing ovaries. Young adolescents, in their teens and early 20s, might have what looks like polycystic ovaries because they have a very high ovarian reserve. It's not the same thing, though, necessarily. And then hyperprolactinemia and even hypothyroidism, which are related to one another, sometimes might give you the appearance of polycystic ovaries on ultrasound. So you have to treat that before you evaluate their ovaries. This assessment of hirsutism is mainly for research purposes, but there is a Ferryman-Gallwey score that's used to characterize the amount of hair growth on a woman's body. This is, again, primarily done for research purposes, but it helps standardize between evaluations because the hair growth can, of course, be very subjective as well when you're evaluating your patients. I generally try to elicit from the patient, do they have hair growth in places that generally women don't want hair growth? And that seems to get me the information I need. Do they have it on their chin? Do they have it on their chest? Do they have it on their inner thighs? Places women don't like it, sideburns, those kinds of things. But if you wanted to use a formal scale, this is the most used quantified scale for hirsutism. So how do you examine these patients? You want to measure their blood pressure because some of these patients are at increased risk for hypertension. You also want to get their weight. And more important than their weight is actually their body mass index. And in particular, their waist to hip ratio. That is one of the most probably characteristic features, especially in my skinny patients. So if I have a patient who's very thin, I'll always ask them, do you gain weight more in your belly, the way guys do, so more of an apple shape, or do you gain them in your hips, kind of more of that female pear shape. Very thin women will still describe that their trouble spot is their abdomen, especially among my Asian women. They'll have kind of very straight hip to waist ratio. So that's sometimes a sign of insulin resistance. We talked about the acanthosis nigricans. That's that brown velvet skin underneath the arms, behind the neck, or in the groin area. And then you want to look for other evidence of something else going on. So you're not just trying to prove that it's PCOS, you're trying to prove that it's not something else. So you want to look for galactorrhea. Are they having milk discharge from their breast? You want to ask them, do they notice in the shower that they get a little discharge from the neck? Or when their breast is compressed, do they notice that? And then you want to look for signs of thyroid disease, as well as anything that could be influenced from the adrenal gland, moon face, striae, anything that would be suspicious of a problem coming from the adrenal gland and not necessarily PCOS. Basic workup, just so you know, we do a lot of tests, and most of our tests are to rule out bad stuff and to prove that it's PCOS, because the truth is, after I spend an hour with a patient getting their history and examining them, I probably have 90% of the diagnosis made. The rest is just to make sure nothing else is going on before you confirm the diagnosis. So it's still really important to do the rest of the blood work, recognizing that it's mostly to rule out bad things and to make sure that they don't need anything else treated before they can receive that diagnosis. So I typically will do my FSH with the estrogen, and the estrogen is really just drawn to make sure that your FSH is reliable. I typically don't do LH because it's not necessary for the criteria, and I'm really just doing the FSH to make sure nothing else funny is going on, like ovarian failure in a patient who might have premature ovarian failure, for instance. Hypothalamic amenorrhea, again, it's not, the textbooks always describe the low FSH and LH, but I've had patients with normal levels of FSH and LH who essentially are ruled out for PCOS. And their diagnosis really is the hypothalamic amenorrhea, especially for the athletic patients. That can be more common among them. It's really important to not just get total testosterone, and in fact, total testosterone is less sensitive than free testosterone. You need to get the total testosterone, though, in order to calculate your free testosterone. So we do the total primarily to get at the more important hormone, which is the free testosterone. Prolactin and TSH to rule out other causes. You do see among patients with PCOS some mild elevations in prolactin. I don't necessarily treat those off the bat. I might monitor them. I would do an MRI, obviously, to rule out microadenoma, but this is not uncommon among PCOS patients. Hypothyroidism, however, can also lead to hyperprolactinemia because of the pituitary commonality and hormone stimulation, and so you need to treat the thyroid condition before you can evaluate that patient properly. We also recommend doing proof of ovulation. So nowadays people can do those kits, those ovulation kits. They're pretty accurate, not perfect. They have about a 5 to 10% error rate in the positive or negative direction. I have an ultrasound in my office, and it's easy for me, so I just monitor them with ultrasound and follow the follicle and eventually prove that they released it. And then if that's too difficult, you could just check their progesterone level after about 7 to 9 days after they've ovulated, assuming they're using an LH kit. But the truth is, once they've ovulated, their progesterone level will start at about 3 nanograms per milliliter and then just rise above that in the mid-luteal phase. So if you see a progesterone greater than 3, then that's proof that the patient is ovulated. This was a really interesting study by actually a colleague of mine. He trained, I think, at UCLA, if I remember, but he's right around the time I was in training, Annie Wong. So he did a paper, 2010 in FNS, and identified that of 720 patients using the NIH criteria, approximately 75% had high androgen levels if you did blood serum levels. What's interesting is that the free testosterone was the most prognostic. So oftentimes people won't even evaluate free testosterone, but that's the most common elevation you'll see. So anything more than, some people say 1%, I use the 0.8%. So if you're approaching 1%, that's probably too high for women. Again, making sure that they're not any medicines that would alter that. So if they've been on birth control pills, you need to give them at least a 6 to 8 week washout before you can get adequate evaluation of free hormones in them. So patients on birth control or recent birth control use, they're not going to give you accurate information. DHEA sulfate, which is produced in the adrenal gland, is often elevated as well, and this is very common among my patients with PCOS. So even if I don't see elevated testosterone, we'll often see the DHEA sulfate is elevated. So that's really an important test to run on these patients. Now, if you have mild elevations, like we see with PCOS, I don't get too worked up about it. I know some people see anything above the normal range on the lab, and they think something must be going on in the adrenal gland. Truthfully, I don't get worried unless that number is several-fold higher than the cutoff. If you see it mildly elevated in the 300-400 range, it's probably related to PCOS or some variation of PCOS. If you start to see it more than the 700 range, then you obviously need to rule out an adrenal tumor, but the truth is you should see elevated testosterone in those patients as well. It shouldn't just be isolated to the DHEA sulfate. So that's another clue if you should be worried or not. If you only have elevated DHEA sulfate but normal testosterone, chances are they probably don't have an adrenal tumor. Again, these patients tend to be low in most of our populations. They could be sent for a dexamethasone suppression test. I tend to just repeat it in a few months to make sure that it's not trending upwards. So in case there is something going on in the adrenal gland, we would pick it up over time. 17-hydroxyprogesterone is actually done to rule out adult onset congenital adrenal hyperplasia. It's reported that maybe up to 5% of those patients that we think have PCOS actually have adult onset CAH, congenital adrenal hyperplasia. You should be more suspicious in patients who are Ashkenazi Jew, Latina, Mediterraneans, Eskimos, don't ask me why, and then Yugoslavians. So in those patients, you absolutely want to rule out 17-hydroxyprogesterone. Used to be more imperative because we'd want to know that for patients who are getting pregnant, because if they were to have this, their androgens tend to be fairly elevated, and it could affect them during a pregnancy if they had a female fetus, leading to androgen changes in that female fetus and possibly ambiguous genitalia. Although that's become more controversial now because it's not necessarily clear that they should be treated with steroids during pregnancy anyway, and that unless their androgens are extremely elevated, most of those female children aren't going to be affected. So I still screen for it, just so patients know, especially because we have some pre-pregnancy diagnostic testing we can do, in fact, on the embryos even, and so it's nice for them to know going in, or their partner can be tested, and they can kind of learn a little bit about what their pregnancy risks would be. Again, the boys aren't affected by that anyway, so you're really just dealing with a small portion of those pregnant women. The best time to make sure when you check the 17, it is a progesterone, so if this is a woman who's ovulating and you check it in her ovulatory phase or the luteal phase, you'll often see an elevation, that's a false elevation. So you really need to check it in the follicular phase and preferably in the morning. But in my experience, as long as it's the follicular phase and they haven't ovulated yet, you'll get an accurate reading. Okay, so borderline levels need to be followed up. And oftentimes we'll have them do a Cortrosyn stim test to classify them as either having or not having the CAH. Total testosterone, I already mentioned, only really done to calculate free testosterone, and unless it's super elevated, I don't get too worried. You will see some women having up to 100, 150 even occasionally, but those ranges are not tumor level concerns usually. And then cortisol you might do in patients who you're concerned might have some other signs of adrenal problems, specifically Cushing's. And so in those cases, occasionally I'll end up doing a cortisol level. It's not usually necessary though. So obesity is not included in the diagnostic criteria, but we did talk about how often women who have PCOS are obese. I think in our Southern California population, at least in my practice, this seems to be lower than the average because people are so health conscious and really manage their lifestyle very well. But it is reportedly occurring in about 50 or more % of women with PCOS. I do note that those patients who have it work a lot harder to stay thin. So there is something about the abnormal hormone environment that makes it harder for these patients to maintain an ideal body weight. It does worsen all the other features that we talked about. So if they are heavy, that'll make all the presentation more similar to that first picture we saw that was described with Stein-Leventhal. The waist to hip ratio is really important, as we talked about. And then thin women can have very polycystic appearing ovaries behave more like heavier women with polycystic ovary syndrome. So they're getting that excess androgen from their ovaries, primarily, not from their rest of their body there. So what do we do with these high-risk phenotypes? So if you've identified patients who either have who are obese or who come from certain populations that might be at higher risk, like Latina, then I definitely recommend screening them for diabetes. So we do the hemoglobin A1C. That's what I do. I think it's simple. People like to do the fasting with the 3-hour follow-up. I usually do a hemoglobin A1C. If it's borderline or elevated, I discuss with them possible treatment with metformin, and if they have a primary doc or a medical endocrinologist, I have them co-manage with me so that they can get them in to see them for post-pregnancy management. People do the fasting glucose to insulin ratio. It's actually not very accurate, unfortunately, so I don't do it anymore. I used to do it, but hemoglobin A1C is easy, and it's pretty predictive. So 20% in these high-risk phenotypes, they have a 20% risk of developing glucose intolerance, and so you can't just screen them once and leave them alone. Even these young women in their 20s, you'll see they're borderline diabetic. I had a patient, she's probably 120 pounds, 5'5", and cholesterol's through the roof, and she's borderline diabetic. So you have to follow these patients closely and don't wait to test them. Again, fasting lipids is another concern that we see in these patients. So I do those in patients who haven't had that done with their primary doc or who may not have a primary doc even. Metabolic syndrome is quite common. 15% of the population in general, twice that among women with PCOS, especially if they're obese. So you just want to screen them and make sure you're not missing that. Certainly this risk goes up as the patients get older, so oftentimes they're not in my care by the time they evolve to this stage. They've moved on, done with their babies. So what are your treatment goals? You really want to address their specific concerns. So first and foremost, you just want to screen them and see what risk they may or may not have. Identify if there's any comorbidities such as diabetes or high cholesterol that need to be treated. Really, really important that often I see get missed, and in fact I've picked up some hyperplasia with atypia in our patients who are young, even in their 20s and 30s. Women who are not ovulating normally or who aren't having menstrual cycles at least every 3 to 4 months and have PCOS have constant exposure of estrogen to their lining. And that estrogen can eventually lead to hyperplasia with and without atypia. So it's really important to protect their lining and to monitor them carefully. Ultrasound's one tool. If they have a thick lining or if it's irregular in appearance, it really needs to be sampled. So a thin lining would be less than 5 millimeters essentially in the follicular phase before they've ovulated. If they're not ovulatory, then you just do a random check, and if it's anything more than 5, they need to be sampled, I think. Or at least force them to have a period with progestin and then reevaluate their lining before deciding to sample them or not. If they're not trying to get pregnant, I usually advocate for them to go on birth control pills. That'll force them to have a cycle. They don't have to have one every month. If they don't want, they can do it every 3 months, but then that helps protect the lining, and you get that add-back progestin, which counteracts the chronic estrogen exposure. If they're trying to get pregnant, then you address those particular concerns. They may need ovulation induction. They may need evaluation of their uterine cavity, because in addition to the hyperplasia, they often can develop polyps from that chronic estrogen exposure. And then if they're really just there primarily for cosmetic concerns, then you manage those, the hirsutism, acne, hair loss on their head, and so forth. So the main thing is to listen to what your patients are really concerned about and make sure you're not missing any medical illnesses that might be going on in the background. So these are some of the comorbidities. We basically have described most of them, but these are pretty well established to be connected with PCOS. People don't realize the sleep apnea, disordered breathing, depression is quite common, and sexual dysfunction. Possible links, we're not so sure, probably as a result of the secondary risk factors. So if they're not managing their or being screened and identified as having high risk, eventually that they're at risk for heart disease, hypertension, possibly ovarian cancer. This is more controversial. Miscarriage, we used to say a lot, but in my experience, that's probably related to other coincidental factors, not specifically to the PCOS itself, and then pregnancy-induced hypertension and gestational diabetes. So prevention, what do? Main first line treatment, always lifestyle. So I always advocate weight loss, exercise, and then a plant-based diet as much as possible to limit the pro-inflammatory condition, which is linked with PCOS as well. You might consider metformin. We used to do it more often and more routinely. I'm not sure it's necessary, and the literature recently confirms that it's probably not needed unless you can document insulin resistance or some sort of borderline diabetic state. So if their hemoglobin A1C looks good, then I generally just follow them and start with dietary changes before introducing metformin. Statins, of course, would be used for long-term prevention, but I typically avoid this if they're trying to conceive, and I advocate can't use it in pregnancy for sure, but I don't even like it before pregnancy. So if they're young reproductive age women, I always try lifestyle, and the statins are more for long-term benefit, not short-term anyway. So I try to get those patients to hold off until they're done having children to treat that with medications. So the endometrial cancer risk is real. If you took 56 obese women with PCOS, 36% of them who had hyperplasia would evolve into cancer if they weren't managed. If they had hyperplasia with atypia, and they saw that in about 10% of this group, 23 would develop into endometrial cancer. So this is a very preventable source of endometrial cancer, identifying these patients and making sure that they're not having unopposed estrogen for many, many years. And again, I've seen it in 20 and 30-year-olds. We'll go on. So here's kind of a summary of what the specific biochemical abnormality will lead to in terms of what we see as clinicians, and long-term what the consequence could be for those patients. So the androgen problem, the chronic estrogen exposure, impaired glucose or diabetic risks, and then the abnormal lipids. I'll go quickly through these. I don't know how many of you deal with hirsutism, but there's many ways to treat it. Hair removal with the lasers is really popular, wax. You can put them on birth control pill. It's actually a great treatment. It takes about 3 months to a year to see any effect, and that can frustrate patients because it is a little bit longer to act, but it's still quite effective, and it's relatively low risk, and it attacks one of the other issues, which is their irregular cycles and protecting the endometrium. Some people talk about doing metformin because it does lower androgens a little bit, but it's usually not enough for them to notice clinically significant changes in hair growth. You can do continuous progesterone therapy, but patients usually don't like that. You could also do cyclic progesterone therapy, but it's more difficult for them to remember. So if there's a reason they couldn't be on birth control pills, then I would recommend the progestin alone therapy. You could do Lupron, but you can't really have them on that for very long, so I don't generally advocate Lupron for those patients. And then anti-androgens, I've seen increasingly patients prescribe spironolactone by their dermatologist, and they're of reproductive age. I personally don't prescribe it in any of my reproductive age women because I know that most women who get pregnant aren't planning to get pregnant. They're unplanned, and so by the time they figure out they're pregnant, they could have already done some harm to their fetus. So I always recommend if they're really not wanting to get pregnant, then they should maybe consider birth control pills first. And if that's not effective, then they can add the spironolactone, but I won't go the other way. But if they're, tubes tied or their partner has a vasectomy and they're not planning on having children, the spironolactone can be used. It requires more monitoring with metabolic panels, so it's more cumbersome to me and has more risk. And birth control pills can be very effective, so I usually start with birth control pills. And then steroids we used to use more, but it's really a short-term treatment. It's not something you can keep patients on for a long time. Okay, so we talked about kind of the managements if they're trying to just background manage their risks. Well, the same thing applies for fertility treatment. First and foremost, I advocate if they're obese to try to lose weight. Ideally, you want to get them with the BMI less than 30. I'd even be more pleased if they could get to a BMI less than 27 or 25, but oftentimes I'll accept 30 because time is of the essence when they're wanting to have babies. So first-line treatment is to get them to ovulate. We can use pills, such as Clomid, or we can use injections. Injections have very high rates of ovulation, but they're costly and they lead to a much higher risk of multiple gestation. You can do ovarian surgery, although this is, in my opinion, outdated. It's not certainly first-line treatment. I may consider it in rare circumstances for patients who can't afford fertility treatments, but it doesn't come without risk for them. And then in vitro fertilization, we're increasingly using because it's so effective, especially if cost is not as much of a concern for patients. But it does cost a lot more than the other treatments, and it does have a higher risk of multiples, but we have very much control over that compared to just giving them the medications and doing timed intercourse, for instance. So weight loss is really important because losing weight will restore ovulation in about 50% or more of those patients, but it takes time. So if you have a patient who's really anxious to have a baby, and if they're older in their 30s, then you probably don't want to wait just for weight loss to kick in for them to succeed for fertility reasons. But if they're in their 20s, it's definitely a good first-line approach. More importantly, we know that women who are heavy starting out their pregnancy have a much higher risk to the pregnancy, and there's epigenetic changes that happen in utero that affect the fetus that may be irreversible. So that's another reason I advocate for weight loss, because it really creates a healthier pregnancy for them, and it makes for a healthier baby. So we've seen that even a small, maybe not getting to the ideal weight, but a small change in their weight can really improve hormone evaluations of insulin and testosterone, and they do see increased sex hormone binding concentrations. Many of them will start to ovulate on their own if they can get below a certain body mass index. So if they're kind of borderline overweight, this is a great first-line treatment, especially while you're still evaluating them. Metformin, again, we talked about, used to be used more often. It's not kind of first line as much anymore, but I still find a role for it, especially in patients who are borderline diabetic, or to help them respond to Clomid, for instance. It does have side effects, and you have to make sure that they're on a therapeutic dose. Oftentimes patients don't tolerate it, so they take a subtherapeutic dose, which in my opinion, they just should skip altogether, because it's not going to work unless they're on at least 1,500 to 2,000 milligrams. And if they're doing 500 a day, I just tell them not to bother. It's not helpful in that situation. There's the classic risks of the kidney and liver toxicity and lactic acidosis, but in our young, healthy patients, those risks are extremely, extremely small compared to the general population. But I do always get a baseline comprehensive metabolic panel just to make sure that their liver function is decent. Some of them have fatty liver, so they might have slight elevations in their LFTs, and then certainly that their creatinine looks okay. So there was a nice randomized trial by Legros in the New England Journal, 2007, that looked at treatment for fertility using metformin and Clomid, and using Clomid alone. So based on this randomized trial, which was a great study in many ways, they concluded that because the live birth rates were so higher in the Clomid with placebo, and it was no different than in the Clomid with metformin, that there's really no role for metformin, especially because when they just did metformin alone, pregnancy rates were so much lower. I think one important thing to know is that they didn't screen patients ahead of time to see if they would have benefited perhaps from the metformin or not. Two, they didn't have the patients on metformin for any length of time prior to initiating treatment, which in my clinic experience, you need at least 2 to 3 months of metformin to see ovulatory changes. Miscarriage rates were no different. That's important to know. So it doesn't seem that it increases miscarriage rates, although we saw a trend to higher miscarriage with the Clomid alone. So maybe the group was too small to detect a difference. I'm not sure. So I still like to, use primarily Clomid, but if there's another secondary gain from doing metformin, I advocate that they get on the metformin. Ovulation induction, we talked about Clomid. You can start it at various times in the cycle, anywhere from day 2 to 5. It helps. It doesn't work in all PCOS patients, but you do see about 80% ovulating. And since we presume their main reason for not getting pregnant is that they're not ovulating, once you get them to ovulate, you see very high pregnancy rates, about 60% among those who are ovulating. But there is a subportion who won't respond to it. We don't do Clomid generally for more than 4 to 6 months, even in this population. If they're already ovulatory, I won't even do it for that long. I usually only do it for about 3 to 4 cycles because the efficacy decreases with continued use. There's another medication we use primarily for breast cancer, but in our context, we use it for ovulation induction. So Femara or letrozole is also a very good agent to use for ovulation induction in our patients. And sometimes I prefer that for some patients over Clomid. So if you wanted to go to the next level of medications, they would be the gonadotropins. So you do your recombinant or urinary FSH products or the HMG products. Very high pregnancy rates within a short amount of time. But you have to be really careful because especially in these patients who have polycystic ovary syndrome, they can end up with way too many follicles, and then you're stuck either canceling the cycle or taking the risk of multiples. Multiple gestation risk is up to 30% in these patients, and it's hard to modify because these patients often have a very narrow therapeutic window. So you can put them on a low dose and they won't do anything. You go up just a small fraction and all of a sudden they produce way too many follicles. Sometimes in those patients I'll combine it with either the Clomid or the Femara, and then you get a more modest response rate without as much risk for multiples. Last but not least, IVF, assisted reproductive techniques. So the nice thing about ART is that it's usually successful. So it gets patients to where they want to be the quickest. I put in here more than 70% pregnancy rate, and those who are younger than 35. We have some more advanced techniques that, in fact, more recently, success rates are as high as 85-90%. So they're very likely to get pregnant with this treatment. They often will have leftover embryos, which for some patients is a good thing, but could be an ethical dilemma for other patients. But if they want to have their future children, they can have these extra embryos left over and then have more children down the road whenever they're ready. And those embryos were created at a time that they were younger. So that preserves their fertility, in other words. There is a risk of multiples, but increasingly we're doing elective single embryo transfer, so the risk of multiples is almost negligible. So you have a lot more control with IVF, but again, it's a lot more costly. So some of the cons is it's relatively costly per cycle, but if you factor in that they want to have multiple children and that the transfer of those embryos down the road is very much less expensive, we see nice studies demonstrating that for family building, this is actually a very cost-effective approach. And from a healthcare standpoint, policy perspective, it costs the system less because you're usually not dealing with multiple gestation pregnancies who can have complications that land the newborns in the intensive care unit. There is the risk for ovarian hyperstimulation, but in my opinion, this has become increasingly manageable with appropriate protocols and some medications that we can use after retrieval to treat those patients. I probably had to hospitalize one patient in 10 years for this, so it's really, really rare. Ovarian drilling, again, Cochrane Library does not support this, but some people are still doing this. I really only reserve that for my very young patients. I don't use anything other than laser when I do it. I don't like to use anything more intrusive or invasive than a laser tip. And really only in those patients who really, truly can't afford any of the fertility treatments to give them some opportunity to perhaps ovulate. The risk is, though, you could certainly cause iatrogenic loss of ovarian function, and I've seen that before where surgeons might be too aggressive and now they're stuck with these patients who previously had too much ovarian reserve and now have not enough ovarian reserve and they're trying to create a family. There can be scar tissue, especially if you're not careful with what kinds of equipment you use. If you're using a lot of heat, you're more likely to see some scarring post-operatively. One benefit to doing it is that you might identify some other risk factors. Occasionally you'll see endometriosis in these patients or scarring, and or you might be managing some other complaints that they may have. So surgery does play a role, but it's not usually my primary recommendation. Okay, so here's a summary of some of the treatments depending on what their goals are. Birth control pills treats the acne and the endometrial issues. Anti-androgens, again, only in women who are done having babies. And then the anti-diabetic agents or estrogen antagonists to protect the lining of the uterus. And then for fertility, we use the Clomid or the injectables to induce ovulation. So conclusions. What about PCOS? Well, it's a multifaceted condition, and it has varying presentation based on the genes that may be involved and then lifestyle factors. There's no clear accepted basis for diagnosis, but I think most of the reproductive endocrinologists and medical endocrinologists are using the androgen characteristic as one of the main features, and then the cycle irregularities, I should say. And then in addition to this having an issue for their reproductive years, you have to think about long-term. Their prenatal implications, because those pregnancies that they're carrying can also have epigenetic changes that affect those offspring moving forward in the future, in addition to passing on those same genes that they were carrying that led them to be at risk for PCOS. Metabolic disorder, which occurs certainly as they get older into their 40s, even though they don't look like they have polycystic ovary syndrome, they haven't lost the disease, it's just evolved into a new presentation. And then making sure that we're evaluating their endometrium if they're not ovulating or if they're obese, to make sure that they're not at risk for endometrial cancer. Treatment goals, first and foremost, education for patients, because they don't often understand what this is, identifying other illnesses that go along with it, and then modifying their long-term health risks. The main thing is just to make sure that we're treating their concerns, because there's lots of options for them out there. That's it. Any questions? Yes, Jane. Thank you. Thanks.